Andrei.
And the next presentation that we will be discussing will be prevention of pain syndrome in case of amputation. And I have the pleasure of inviting our next speaker, Dr. Subbotin from the Vitaly Clinical Hospital. Yes, good afternoon, my dear colleagues. And indeed, I would like to speak in support of the hypothesis suggested by the previous speaker, because indeed it would be extremely difficult, if possible at all, to improve any significant achieve any significant improvement in this important sector of our function without your assistance. And here, in case of research, both academic and operational research has been studied, looking into surgical solutions for pain syndrome and also trying to prevent it from occurrence. One of the techniques in response to one of the underlying reasons would be neuroma formation. In the opinion of our authors as well as our co-authors, the pain syndrome accounts for 50 to 80% of all cases of amputations. It's also quite well described in different literatures, different types of neuroma treatments, but we decided to focus on those suggested by the colleagues from the Michigan University. The fact is that when establishing the platform for the formation of the stump that will be getting in contact with the extremity following its amputation, they observed that in most cases the neuroma and its terminal bulb is not developing appropriately in case of the respective excision. And this is where regenerative peripheral nerve interface technique was designed as a technique which prevents further buildup of such complicated following amputation. So here on the left you can see the schematic image and the live image of how it might look in case of amputation. So we are dividing the nerve into fractions, which later on are inserted into special pack of devascularized nerve tissue, which later on can be used as a platform for formation of a specialized prosthetic device, or submerged into the tissue to make sure there is no development of the neuron cells. To demonstrate this in action, I'd like to refer to two patient cases. One of such cases was quite prolonged, and this was almost 5 months following the amputation, experiencing quite significant pain, which had to be medicated. And the intensity was quite high, as you can see, a 6 to 7 out of 10-point scale. So we performed the RPNI, and the syndrome pain was mitigated. The similar was performed in a secondary amputation case, which is described here. So here, as you can see, the stump size is quite extended, and the mechanism of neuroma formation was associated with a fragment left following the amputation. So here is the neuroma formation, and here you can see the dissection of other nerves. Further on, speaking of this patient, he was prepared for a re-amputation and the stump formation, and following that, the patient was discharged without any pain syndrome. Another case, speaking of the patient with progressing pain syndrome, re-amputation was also performed with a stump formation using the RPNI, following which the pain syndrome has been mitigated significantly. Over the week times following the amputation, the pain syndrome was almost absent. So again, primary hallucinating amputation would be indicated in similar cases, but also the follow-up care is important, particularly to make sure there is no debris or fragments left following the amputation, which might result in some additional irritation, thus interfering with the process of stump formation and aneurysm. Here you can see this done in live settings. So we are dissecting the key stems, which are later submerged into these tissue bags. And this would be also helpful in case of bionic prosthetic hair in the future. So now these slides are maybe outdated because now we have another couple of patient cases in progress. So we will soon provide you with updated information regarding the patient cases who are currently undergoing such treatment. But overall, we have all the grounds to suggest, at least based on our assessments, that RPNI could be quite helpful both in terms of stem formation, but also reconsidering a second wave of amputation and follow-up care to the patients where re-amputation might be helpful. With that, I finish basically the content of my current presentation, but let me also use the time available within my slot is using the blood vessels in management of amputations, particularly using the grafts. In the cases of donating the organs, because our health professionals, the phlebotomists, they also may be included into the field of organ donation teams to collect some vascular tissues. At this moment, this is complicated due to the missing legislation and the current position of the Ministry of Health. But in many cases, there are interim solutions which can be applied, and this will be a lot more effective and efficient at the same time as compared to other tissues. And also, collection of an autovenic donated material could be more beneficial for the patient instead of third-party donation. Also, grafts from the autopsy material could be quite helpful, particularly those which can be covered by such autopsy material, which has been tested in a number of patient case management, sometimes having life-saving effects. Thank you, dear Vitaly, and thank you also for saving some time for our interactive discussions. So, since we have the feed of questions coming in, no, this is not up to you. You did perfectly well, Tim.
Was the follow-up? Did you do a follow-up, and for how long for the pain?
Вибачте?
After the surgery, follow-up time?
На жаль, у нас нема можливості.
Well, unfortunately, we don't have any technical capacity to provide a long-term follow-up for our patients, because usually they are discharged after completion of the inpatient care period, and if they are stable enough, then most probably we will never see that patient again. So I cannot answer your question directly. Understood, and thank you for your open question. And just to make sure that we observe our household rules of communication, if you have a question, do raise your hand to be provided with a microphone. Seeing none of that, then let me make an assumption that some of the questions are reserved by the participants for the lunch break time, for our networking opportunities. Otherwise, in any case, we are happy to thank Dr. Subbotin for your kindest contribution to our panel. Also, dear participants,